Want more control over your life? You need more control over your money. Hi, I'm Jean Chatzky, and that's why I started the Her Money podcast. From understanding your money personality to taking steps to earn more, spend wisely, invest for tomorrow, and protect it all, I can help you get there. So join me. Subscribe to Her Money with Jean Chatzky wherever you get your podcasts.
Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach nursing concepts and share tips on how to thrive in nursing school and at the bedside. I am so excited about this episode today. I learned a ton of fabulous tips talking with Dr. Sehgal, a urologist who is coming on the podcast to share some fabulous tips and information about troubleshooting and managing Foley catheters, things that as a nurse for more than 10 or 11 years, I had never heard before. So I'm really excited to share those with you today. Before we do that, let's take a quick minute for a listener shout out. This one goes out to Kaylee, who says, I just wanted to pop over here to say thank you, Nurse Mo. I am in nursing school and I bought Crucial Concepts Bootcamp on recommendations by a classmate. I'm still working through it, but I absolutely love the way it is set up and how efficiently things are laid out. It is helping me see what I already know and what I need to focus on. I don't start clinical rotations until August, but my confidence is much higher after starting this program, and I will definitely be getting more courses. I recommend it to my entire friend group and school cohort as well. Kaylee, thank you so much for taking time to submit your feedback about how Crucial Concepts Bootcamp is helping you. I'm so proud of you. And like always, I encourage my listeners to send me an email when you get your license so I can celebrate with you. If you'd like to learn more about Crucial Concepts Bootcamp, which Kaylee mentioned, then I will link to that in the episode notes. You can also go to straightanursingstudent.com and click on courses in the menu bar. All right, so today I am super excited to have on the podcast Dr. Sehgal, who is a board-certified urologist working in Western Pennsylvania and West Virginia. And he's absolutely fabulous. You're going to learn so much from him. One thing I really enjoyed about Dr. Sehgal and talking to him is that he really clearly loves teaching. And he has a YouTube channel, which he'll talk about briefly when we get to the interview. But I just want to tell you, absolutely go check this out. It is absolutely fabulous. That YouTube channel is UroCoach, UROCoach, and you can find him on YouTube. So without further ado, let's hear from Dr. Sehgal. Okay, so I'm joined here today with Dr. Sehgal. So I'm going to let Dr. Sehgal introduce himself and tell us a little bit about what we're going to be talking about today and his areas of expertise. So take it away, Dr. Sehgal.
Yeah, thanks so much for having me, Maureen. So my name is Dr. Sehgal. I'm a practicing urologist in Western Pennsylvania and West Virginia. We're going to delve into indwelling urinary catheters, how to deal with them, how to deal with troubleshooting them, how to manage them, because I think it's a super useful skill. It's something that can be daunting for nurses, and I just want to try to empower everybody. I'm also one of the founders of UroCoach, which is a library of urology education videos on YouTube.
Okay, very cool. So what is your YouTube handle before I forget to ask?
Sure. It's at UroCoach. So it's not a European bus. It's UROCOACH. UROCOACH. Yeah.
Okay. A European bus also sounds really great. Okay. So that's a great resource that I thank you for sharing that. Okay. So you mentioned Foley catheter management, Foley catheter troubleshooting. So where do you want to start? You want to start with general management, and then we'll get into more of the specifics about if you've got an issue with an insertion or maybe an outflow obstruction, things like that?
Sure. Yeah. I think, I mean, some of the fundamentals, obviously, we try to keep catheters in for a very limited amount of time. I think most nursing individuals know that, nurses know that. Clean intermittent catheterization is kind of a quote cleaner technique than leaving an indwelling Foley catheter. But tons of patients in the hospital have Foley catheters, right? I mean, every other patient has a Foley catheter, and a common thing that nurses have to troubleshoot is the catheter's not draining. What do I do next, right?
Yes.
And so I think, and it's stressful, right? You're there, you're with the patient, you don't know whether it's that they have low urine output. Is the catheter obstructed? Is there something else going on?
Right.
And the nurses are the front line to try to figure this out. So I wanted to try to give them some tools on how they can start to think about this problem, because it's something they may face on every shift. But anyway, I think one of the more useful things to do, Maureen, when you're encountered with that situation as a nurse, is to just flush the catheter. And
absolutely.
Sometimes, and so it's I always say as urologists, we're kind of like plumbers, right? So what you want to do is get a TUMI syringe, the same kind of syringe that you would use to flush a nasogastric tube with, and you use 30 to 60 cc's of fluid, sterile water or normal saline. And what you want to ensure is that the fluid that you put in, you are getting back, right?
Yes.
Because that confirms that the catheter is in a hollow viscus. In this case, it's in the bladder. If it's not in the bladder, if it's in the prostate, or if it's blown up in the urethra, you're either going to see fluid immediately leak around the catheter when you instill the fluid in, or when you put the fluid in, it's not going to come back out. So I think that's a useful kind of first step for nurses to try to troubleshoot a Foley catheter, because if you can flush that catheter, you can feel pretty confident that it's in a good position. And so an outflow obstruction is not necessarily the reason why that patient isn't making urine.
Mm-hmm. Right. And I've done this a million times. I learned this as a brand new nurse, because guess who called the doctor about a concern about urine output when really all I had to do was give it a good flush, because the patient had a lot of sediment in their urine, and just giving it a good flush also just kind of helped maintain that catheter patency. Was one of those super embarrassing. I always say I learned things the really hard way, either really expensive or really embarrassing. And that was definitely one. So if anybody can.
I did too.
So if you can avoid doing that, great. So follow Dr. Sehgal's advice. When you're faced with low or no urine output, get in there and try flushing that catheter. So something you said that was news to me and now is going to make me super paranoid whenever I'm inserting catheters in my male patients is that the catheter can end up inside the prostate?
Yeah. Not that I've ever done that before.
Okay.
Well, I may have a few times, but we can usually get ourselves out of jams as urologists, right? So one of the keys to try to figure that out, Maureen, is when anybody puts a catheter in, sometimes what will happen is, you're classically taught, whether you're a physician or a nurse, that you want to put that catheter in until you get urine out, right?
Yes.
I mean, then you know that you're in the right place. But sometimes what happens is that when you look at these catheters, if you ever take a Foley catheter and you inspect it, there's the holes are towards the end of the catheter, but the balloon's actually behind it, right?
Mm-hmm. Right.
So what can potentially happen is that you put that Foley catheter in, and the holes have just gotten into the bladder, just gotten past the bladder neck, but the balloon itself is still in the prostate. So if you inflate the balloon prematurely, then yes, it can get inflated in the prostate and cause some trauma, which we can fix as urologists, but obviously you don't want to be in that situation.
No.
So right. But the trick that I usually tell people is that you always want to, quote, hub, H-U-B, hub the catheter. So you want to push the catheter all the way in until it meets the urethral meatus in men. Because if you get urine out, and that catheter is hubbed all the way in, you're almost certainly in the bladder. So that's kind of the way to ensure that, Maureen.
And you don't have to be worried about going too far. It's just going to coil up or what, just be in the bladder. And then when you inflate the balloon, you give it that very gentle kind of pull to seed it, and then you should be good to go, right?
Absolutely. And that's a great point, is that, and I take that for granted sometimes. If you push that catheter in and you push it in too far, there's no such thing as that. You're not going to push it in too far. It's just going to coil in the bladder. All the tools we use to operate in the bladder, a soft catheter is not going to rupture the lining of the bladder. And that actually, when you mention that, my gears are moving in my head when you say that. One thing that can be confusing sometimes is actually when you put the catheter in, sometimes there'll be so much lube on the tip of the Foley that you won't get urine out. And it can be really stressful, right?
I was just in this position a few weeks ago, and we kept thinking, we're not in the urethra. We're in another spot. And oh my gosh, I think we did 3 attempts. Turns out the nurse that got it went in the exact same location we had. We just had way too much lubricant. And so there was just no urine flow. So really uncomfortable for the patient. That poor sweet lady had to endure us fumbling around for a good 30 minutes to try to do this insertion. So that's a really, really good tip. So let's talk about that. So too much of the lubrication. I'm assuming what you're saying is you don't have to, glop it on there. Just a coating is enough?
Yeah, I think if you're going to err one way or the other, it's good to put more on there than less. Mm-hmm. But I agree with you. I think just making sure that the catheter itself is well lubricated is sufficient than making a glop of lubricant on the end of the Foley catheter. One little trick too, while we're talking about that, is let's say you put that catheter in and you've hubbed it and you've put in so many catheters and you're like, I know I'm in the bladder, but you don't want to fill up the balloon because you're not 100% sure because you're not getting urine out. And the reason why is there's so much lube at the tip of the catheter. One little trick that you can do is you can take the syringe that had the lube in it, that's usually in the Foley kit, and then just make that an air syringe. So just pull back air and just push that into the Foley catheter as if you're going to flush the Foley catheter. And guess what happens? All that lube moves from the tip of the catheter, then all of a sudden you get a flush of urine back. So you have something in your Foley insertion kit that you can use as a troubleshooting mechanism for this Foley catheter. So that's just one thing I wanted to tell people.
I love that tip. I'm gonna use that and pretend. I'm gonna pretend I thought of it myself. Just kidding.
I take credit for it.
No, that is an awesome trick, and it is definitely going to come in handy. Okay, so what about hubbing in a female patient? Is that necessary?
So it's not necessary in a female patient. The distance, as we talk, I'm thinking about how long the urethra is in a woman. Right. We're talking about just a centimeter or two. So in reality, for you to be able to, as soon as you get urine in a female patient, you're in the bladder. And for you to be able to just anchor that Foley in, you're going to have to push it in a little bit farther, and then you're well within the bladder. So that's not as much of a concern in women. In practice, for going on 11 years now, I don't think I've seen a Foley catheter balloon inserted or inflated in a woman's urethra. So don't worry too much about that.
Yeah. I imagine they would immediately complain of some pretty significant discomfort if you started inflating at that time.
For sure.
Okay. So I love these tips. These are great. Let's talk a little bit more about catheter insertion troubleshooting. My mind is full with all the potential, pitfalls and complications that you can have. It's not as easy on a real person as it is in the lab at school, right? So everyone has, differences in their anatomy, and it's, again, not always so easy. So can you go through some troubleshooting things? Sure. And if you don't mention a couple, I've got a couple that I do want to bring up.
Yeah, absolutely. So one of the things I think regular Foley insertion is very well taught in nursing school in general, but oftentimes you'll hear, primary care doctors that are given this order, urologists that are given this order, or if a catheter can't be inserted, nursing rightly should bump it up and talk to a urologist, talk to the MD on call, and say what to do next. And invariably, it's put a coudé catheter in, right? Put a coudé catheter in. And I think that oftentimes us as docs just take for granted that people know how to put a coudé catheter in. And it's not necessarily easy. And I'll tell you why. These catheters, I don't know how many of the listeners have seen a coudé catheter, but essentially what it is, when you look at a regular Foley, it's a straight Foley, right? It's a straight shot.
Yes.
It goes directly into the urethra, which makes perfect sense in women. The coudé catheter has a curved tip. And the reason for that curve in general is because it kind of contours to the shape of the prostate. So when we're doing cystoscopies and we're doing cystoscopic surgery, when we start going from the urethra into the prostate, into the bladder, we have to kind of drop our hand and force our hand up to get the scope into the bladder. And that's what a coudé catheter does. It has a natural curve to it, or a man-made curve to it, I should say, that will go with the contour of the prostate to land in the bladder. But the problem with it is that when you put a coudé catheter into the urethra, how do you know which way the tip is pointing, right?
Exactly. So I have no idea.
It's very difficult. And why should you, So when we tell people put a coudé catheter in, they say, well, I know when I put it in the urethral meatus, I know where the tip is, but now the tip's gone. The tip's in the urethra in bed. So these are the two tricks that I want to kind of disseminate to people so that they know where the tip is once they've inserted in the urethral meatus. Number one, if you examine a catheter, you'll see this, what we call a vein, vein, on the top of the catheter. It's like this dark line, okay? And that vein is always in line with the tip that goes upwards for a coudé catheter. So when you put it in the urethral meatus, if you leave that vein upwards at the 12 o'clock position, you can be assured that the catheter is going in with a tip upwards, which is what you want with a coudé catheter. That's number one. Now, some people say, I'm looking for this vein. I don't see any vein. I can see veins in arms, but I don't see veins in Foley catheters. But the other thing that you can remember is the balloon port, right? Where you fill up the balloon is always on the same side as the tip with the Foley catheter. So if you put that in the urethral meatus and you say, man, I don't know which way that tip is pointing. Is it pointing left, right, up, down? If you take your eyes back and you get the balloon port to be at the 12 o'clock position, and you push straight in, then that coudé tip is at 12 o'clock as well and going in the right direction. So those are the two things that you can use, two tools that you can use at the bedside tomorrow to be able to know which way the coudé tip is pointing when you put a coudé catheter in.
Okay. And are these generally only used in male patients because of the prostate situation?
In general, Maureen, for some women will have kind of a, especially in older women, they'll have sometimes a stenotic urethra, and we'll use coudé catheters because the urethra is such a shape that it lends itself to being able to be cannulated with a coudé catheter.
Okay.
But in general, it's for men. Yeah.
Okay. I understand. Okay. Thank you for the clarification. I had never heard that about the vein or the balloon helping you with your orientation with that catheter. So that is absolutely super helpful. Okay. What about any other troubleshooting tips for catheter insertion?
So one thing that's really important is for women, right? So we kind of take for granted that, it's a woman, just put the catheter in. The urethra is really short. It's going to be easy to put it in. But sometimes it's not about their genitourinary anatomy. It's kind of their whole body habitus, right? If they have issues with obesity or if they have orthopedic problems, it can be hard for them to get their hips up in the air, right? So if you imagine when they're in a bed, and a lot of these beds have, all these different settings that they're in this big divot, right? And then these nurses are asked to put a Foley catheter in. It can be hard because you're trying to get underneath the divot in the bed to access the urethra to put the catheter in. So one tip is if you're having a hard time putting a catheter in a woman, the first thing I tell you is always get more hands on deck, right? So don't be afraid to ask other people on the floor to help you with the retraction, help you with positioning. I had a resident that used to teach me when I was training that said, if you can't get a catheter in a woman, it's always an effort issue, which isn't always true. But what it means is that, the more hands, the better. So that's the tip. That's the first tip with difficult female catheter insertion. The other is to try to use, sometimes I feel like we're like MacGyver, which is like a dating me. It's a show from the 80s. But,
I'm right there with you.
To try to get the pelvis you try to get the pelvis in a position where you can more easily access the urethra. So you want to try to use tools that are available to you, easily available to you. And there's bedpans on every nursing floor. So if you take a bedpan And again, get some other hands on deck, and you can somehow get that bedpan underneath the woman and turn it upside down so that the big part of the bedpan is underneath their hips. It'll lift up their hips, and they'll sit on that, and suddenly the urethra is popped up in a location that's more easily accessed. So more hands on deck, and use a bedpan to kind of prop up the patient are some useful tips for women.
I've never seen that done, and I'm also going to use this trick at my very next opportunity.
Good. I'm glad.
That sounds really helpful. Okay, what about a patient? This happened very recently. I work in the recovery room right now, and we get a lot of patients after their hip surgeries, and depending on the type of hip surgery, they have some hip restrictions. So I had a patient who could not do any external rotation of their femur. So what would you do in a situation like that where you can't really get the thighs apart because of something like a surgical restriction, or maybe just severe arthritis, which I've seen many times, patients who are in wheelchairs with severe contractures, very difficult to manipulate their anatomy and very uncomfortable for them. So any troubleshooting for that, are there alternate positions or anything that can be utilized?
That's actually that's a great point. That's a very difficult situation, even for us as urologists, because it's a matter of really trying to maximize their contralateral mobility, right? So if they had, a left hip replacement, you really want to try to, within reason, crank on that right side as much as you can. Yeah, to get as much retraction as possible, because that's all you can do. Obviously, you don't want to do anything to jeopardize the surgery that they just had. Mm-hmm. I have also, when you're in a difficult situation, I think the nurses should feel empowered to, talk to the orthopedic surgeon and say, "Listen, we got to get the urine out of this person's bladder. How much is it okay to externally rotate her hip or his hip?" Her hip when we do this. And frankly, they could even be there to watch how much you're rotating them with their aid and their guidance. You can try to maximize how much you can rotate the limb that's just been operated on. So I think maximizing, the contralateral mobility and then consulting with the orthopedic surgeon are the two tips I would give for that, Maureen.
There are really many reasons to listen to our podcast, Big Picture Science. It's kind of a challenge to summarize them all, Molly.
Okay, here's a reason to listen to our show, Big Picture Science, because you love to be surprised by science news. We love to be surprised by science news. So, for instance, I learned on our own show that I had been driving around with precious metals in my truck before it was stolen.
That was brought up in our show about precious metals and also rare metals, like most of the things in your catalytic converter. I was surprised to learn that we may begin naming heat waves like we do hurricanes. Prepare yourself for heat wave Lucifer.
I don't think I can prepare myself for that.
Look, we like surprising our listeners. We like surprising ourselves by reporting new developments in science and while asking the big picture questions about why they matter and how they will affect our lives today and in the future.
Well, we can't affect lives in the past, right?
No, I guess that's a point. So the podcast is called Big Picture Science, and you can hear it wherever you get your podcasts.
We are the hosts. Seth is a scientist. I'm a science journalist, and we talk to people smarter than us. We hope you'll take a listen.
What about, I see this a lot. I saw this a lot in the ICU when I worked there. I see this a lot in the recovery room, is continuous bladder irrigation. Yeah. And a lot of times when I take the patient up to the floor, if there's a nurse that has never worked with CBI before, they often have a lot of questions. So can you talk about maybe the indications and what kind of patient would have CBI and how it's safely managed?
Yeah, absolutely. So I think the first thing, so CBI is always, I shouldn't say always, emergency room doctors will initiate it as well, but very frequently it's initiated by the urologist, right? It's their desire to run irrigation through the bladder. And the idea behind it, just to talk about the general idea, and then we can talk about the way the catheter is constructed, is we're trying to run irrigation into the bladder to prevent blood clots from accumulating in the bladder, right? Yes. So a continuous bladder irrigation catheter has 3 ports. It has an inflow port, which is on the side. It has the outflow port, which is a typical outflow port that you'll see on any Foley catheter. And then it's got a balloon port. which is the typical balloon port that you see on any Foley catheter. So really the only extra port is the inflow port. Now you'll know which one's the inflow port because it'll be slightly smaller than the outflow port, and it'll be off to the side. It won't be a direct shot from the main Foley catheter. And that's where the irrigation goes into the catheter, right? And this irrigation is at the discretion of, I know the prescribing doctor, but usually we'll use normal saline because it's, isotonic with serum, et cetera. So the irrigation runs in and then it comes out the outflow port. And with the idea that, if the patient is having some blood in the urine from a bladder source or from the prostate, we don't want that blood to collect in the bladder because then they can eventually end up in clot retention. So if we can run irrigation in there until the bleeding stops on its own, then that clot will exit the bladder until the urine's clear, and then we can stop the irrigation. So that's the rationale for it. Now, one of the things that's really challenging with continuous bladder irrigation, it's funny because I was just doing a surgery this morning and we acquired continuous irrigation, and this happens in the operating room all the time, is staying on top of the irrigation, right? I mean, nurses are busy, especially with the staff shortages in the whole country, and it's hard for them, to manage the continuous bladder irrigation, even with their whole care team. So I think making sure you have a bunch of bags on the floor and calling for them in advance will help you, help make sure that it doesn't run out, because depending on how fast the continuous bladder irrigation goes, you can run through a 3,000 bag just in a few hours, 3,000 TC bags. So that's one tip I would give you. And then the classic thing is, what do you do when the catheter is not draining in the CBI patient? Now, this is different than what we talked about at the beginning of the conversation.
This is scary.
Because, exactly. This is scarier because what's happening, just to explain the plumbing behind it, I think a lot of people probably get it, but there's irrigation going into this person's bladder and nothing's getting out. So not only is the Foley catheter not functional, but we're actively putting them in urinary retention. So step one, the catheter is not draining, turn off the continuous bladder irrigation. That is step one, okay? Yes. And then step two goes back to what we talked about initially, Maureen, where you want to flush the Foley catheter. Usually in individuals with continuous bladder irrigation, they're using continuous bladder irrigation because of hematuria, right? So very often they'll have a clot that's obstructing the outflow of urine. So simply flushing the catheter will get rid of the obstructive clot, and then you'll see a gush of urine. It's really satisfying, right? When you see a gush of urine come out from the continuous bladder irrigation, and then you can start the irrigation again. So that's the other tip for it.
Yes. Yeah. And to that, I would just add, just keeping really close eye on that Foley bag. You don't want that to fill up because then it could just backflow. And now you're setting them up for retention and a UTI.
Great point.
So,
Great point.
Yeah. So having your collection device that you drain it into, having a couple of those handy, and just being really aware that you're probably going to be emptying that Foley collection bag pretty regularly, every half hour, every hour or so. So of course, depending on how fast that irrigation is coming through. So let's talk now. We talked about, urinary retention when we're doing irrigation. What about a patient who you suspect has urinary retention, or they're maybe not putting out any urine, and you need to do a bladder scan? Let's talk about how to do that so it's effective. If anyone listening has done any bladder scanning, you know that it's very dependent on the technique of the person doing the scanning. So how can we get our best assessments using this tool?
Right. Yeah, it's a great question. So just to backtrack, one other tip that I would give you, let's talk about the patient that has the Foley catheter and you're not sure if it's functional. Let's say you flush the catheter and you're like, I think I'm getting what I'm putting in back, but I'm not 100% sure. You can use a bladder scan in that situation too, right? I mean, you can take the bladder scanner and put it on their abdomen and get a number on it. And if the number is 0, then you can feel more confident that when you flush the catheter, you were doing it properly and the bladder is being drained versus if you get a high number on the bladder scan. But so that's just one tip for Foley catheter troubleshooting. But I think what happens oftentimes with bladder scan is that, not everybody's urologist and people don't always know where the bladder is. So I think one tip is if you're with your patient and you feel for the symphysis pubis, like their pubic bone, okay, and you just go 2 finger breadths up from there, you're going to be right over the bladder. So it's oftentimes much farther down in somebody's body than people realize.
Okay.
I've seen, and it's not their fault, but I've seen people, doing bladder scans around the umbilicus or in the mid-abdomen, and that's really not where the bladder is. So one tip is to try to feel for where the pubic bone is and just go about 2 finger breadths above that. If the patient's obese, you want to try to use one hand to pull back their pannus so you can get a nice flat surface that you're doing the bladder scan on, okay? And then make sure you remember this is an ultrasound transduction technique, so make sure you use plenty of lubrication where you're doing the bladder scan because you want to get an accurate reading. So those are kind of the tips and tricks with bladder scans. One, and this is one thing that individuals can sometimes get confused by, and we can get confused by this as urologists too, is the nurses will call and, they'll say the bladder scan's really high. It's 500, 600 cc's. And you're thinking about it and, maybe you've bladder scanned the patient before or you've catheterized them before. And for whatever reason, you don't think there's that much in their bladder. And if you get a good history, sometimes these patients with ascites or intra-abdominal fluid for other reasons, the bladder scanner will actually pick up that fluid, right? So it'll read high, but it's actually just the ascites that they're picking up in the abdomen. So that can be one reason why the bladder scanner would be misleading, Maureen.
Okay. I've never thought about that, but it makes absolute perfect sense. So one more question about bladder scanning. And I always have trouble with this. So do you aim straight down towards the spine or more towards the pubic bone?
Yeah, I would aim straight down towards the spine.
Okay.
Yeah.
All right. Thank you. Okay. And then what would be a worrisome bladder scan value? Let's say I've got a patient after surgery, for example. A lot of times patients have urinary retention after surgery, especially if they've had maybe like an epidural or something like that. And they're starting to come around, they're moving everything, but they're telling me, I really have to go to the bathroom, but I just can't. I'm going to scan their bladder. When am I going to get concerned about the volume that's in that bladder?
Yeah, that's a great question. I think that you actually hit the nail on the head by saying when the patient starts complaining, right? Because if they're complaining, then there's a problem. They feel like they're not getting urine out, and everybody's bladder capacity is different, right? So I may hold 500-600 cc's in my bladder. Somebody else may only hold 200 cc's in their bladder. So, urinary retention is a relative thing. If you have a smaller lady that only has 200 cc's in there, she may feel like she's going to jump through the roof, and that meets the criteria for quote urinary retention. In our clinics, when we do a bladder scan, it makes urologists happy when the number is less than 150. So if somebody's emptying their bladder, you do a post-void residual, and it's less than 150, you can feel pretty confident they're emptying their bladder effectively. Okay. When it gets above 150, some people live with very high post-void residuals. So some people live with bladder scans, the post-void residuals 200-300 cc's. When it starts to get that level, though, I get worried. I want to make sure that their upper urinary tracts are protected, that they're emptying effectively enough to not cause any upper tract dilation, hydronephrosis, et cetera. I think as kind of the front lines with nurses, I think if it starts getting above 300 cc's, that's the time to kind of bump it up, talk to somebody, and figure out the next steps.
Okay. I'm just curious if you have any good tips for encouraging natural voiding in that patient who feels like they can't go. We learn, little techniques in school, like pouring warm water over the area or turning on the faucet, things like that. Helping the gentleman stand up. Are there any other little tips that could maybe help someone void naturally before we have to go to an in and out cath?
Yeah, that's tough. It's really tough because usually those individuals are having multifactorial urinary retention, right? So somebody that's post-op, it's anesthesia, they probably got some narcotics, they're in pain, they're immobile. So I think everything that you said are great first steps to try to get them to void.
Nobody wants a catheter.
Right. Yeah. Right. No. And we don't want to put catheters, and they're an infection risk. But So I think if they can ambulate, that's great. If you can relieve constipation, that's great. If they can limit their narcotics, all of these things. Now, some of these things can't be done in an acute setting, but all these things are going to help them be able to empty their bladder, quote, naturally, as you said.
Right.
Flomax, we prescribe Flomax all the time, but it can work pretty darn quick too. And some orthopedic surgeons will actually, for patients that are at risk of urinary retention, will give them a dose preoperatively to promote their bladder to empty postoperatively. So, it may not work in seconds, but it can work, within a couple hours. So that's another, thing to discuss with the MD. Yeah.
That's a great tip. I had this poor patient once who had to void, sometimes they go through a voiding trial with, and if they don't pass their voiding trial, we have to put the Foley catheter back in, and they go home with the Foley catheter for a day or two. And this poor woman was not able to void spontaneously. And we were sitting up on the bedside commode for probably a good long while, maybe even up to like 30 minutes, 45 minutes. She still can't void. And, if I'd known about maybe calling for something like that, that would have been really helpful for her. She ended up staying for hours because she just could not void. So, okay. Very, very helpful. All right. Let's talk a little bit. You mentioned a minute ago about infection. So we all know that indwelling catheters come with a really high risk of infection. So I want to talk a little bit about maybe early recognition. I mean, hopefully we don't get to that point because we prevent it, but early recognition of a UTI and how to maybe interpret a UA or a urine culture so that you can call the MD, knowing what you're talking about when you get those results back, and then preventing it in the first place.
Yeah, in the setting of a catheter, Maureen, or just in the
setting of a patient who has a Foley catheter. Yeah. Right.
So that's a very difficult situation too, because invariably, if you take a patient that's had a catheter in for 24 or 48 hours, and certainly patients with chronic indwelling catheters, if you take that urine specimen and you culture it, you're going to get bacteria. So invariably, they're going to have some bacteria growing into their lower urinary tract because their sphincter is being bypassed with the catheter itself. It becomes a matter of, do they have constitutional symptoms, right? So are they feeling, what are some of the other symptoms of a UTI? Do they have low back pain? Do they feel malaise? Is their urine acutely malodorous, right? Is it smelling poorly? Do they have a low-grade fever? Do they have a high-grade fever? So do they have nausea, vomiting, and you can't figure out why? So it becomes very tricky when they have a catheter in, because if you're not sure why they're having some of the constitutional symptoms that you're having, I think by all means we should send off a urine culture and then treat it, especially if they don't have any other reason why they're having those constitutional symptoms. I think a urinalysis is very difficult to interpret in the setting of a Foley catheter. In fact, I probably would just throw the urinalysis out in that situation.
Okay.
But I think a urine culture does have utility, especially if they have some of the symptoms that I mentioned, and we're not sure why. I mean, they don't have pneumonia, they don't have a URI, they don't have other issues in their body, and then we get a urine culture, and we can't just chalk up that urine culture to just they're having a Foley catheter. You can obviously have a Foley catheter and a pathologic urinary tract infection. So I think it's worth sending off a urine culture in patients with an indwelling Foley with other symptoms that we're not sure about. That makes sense.
Okay. And then what about preventing a UTI? So there's lots of things that we do, starting with the sterile insertion. Any other great tips for preventing a UTI in a patient who's got an indwelling catheter in place?
Yeah, I think the best thing is just to get the catheter out as soon as possible. I think, you got to remember, nature made a way of having a urethral sphincter that is closed off. And now we bypass that with a Foley catheter. So it's very difficult to limit somebody's ability to get urinary tract infections when the catheter's in place. I think for patients with urinary retention or frequent incomplete bladder emptying, it's really worth considering doing clean intermittent catheterization or sterile intermittent catheterization rather than an indwelling Foley. A lot of people will think that doing intermittent catheterization is a higher infection risk because it sounds intuitive, right? You're putting the catheter in and out, so you keep introducing bacteria, but it's way less of an infection risk because you're not having a continual bypass of somebody's urinary sphincter, right? You're only bypassing that sphincter when you put the catheter in to drain the urine out.
Mm-hmm.
When you take it back out, the sphincter's closed again. So that's one tip I would give people. Maybe bring it up with the doc. Hey, why don't we intermittently catheterize this patient? It obviously is more difficult for nursing staff to do it, but it can help limit urinary tract infections for sure.
And then would that be done on a timed schedule or based off bladder volume?
Yeah, so you can do it either way. Certainly, if somebody's not voiding, then oftentimes we'll put them on a time schedule every 6 to 8 hours. They'll get intermittently catheterized.
Oh, that's not bad. I was thinking it would be like every 2 hours, which would be really hard to manage. So every 6 hours.
Yeah, that's tough. Every
6 hours would be. I feel like that'd be pretty manageable.
Yeah, everybody's different, but I think that's a reasonable time frame. But, with bladder volumes, one of the nice things about intermittent catheterization, too, is it gives people a chance to do kind of a continuous void trial, right? So if you empty their bladder at time point A, let's say you empty their bladder at 8 a.m., now you've given them another chance to empty their bladder. Whereas if they had a Foley catheter in, you really don't know what's going on with their bladder function. You don't know if, their bladder has, quote, woken up after anesthesia, after their immobility, after their constipation has resolved. So it gives you the opportunity every time you intermittently catheterize them to empty their bladder. So, one of the parameters could be, intermittently catheterize the patient for post-void residuals greater than 400 cc's. And so you can do it either way. You can do it if they're not voiding every 6 to 8 hours, like we mentioned, or the parameter can be based on how much is left over in their bladder.
Got it. Okay. Very interesting. Very good. Yes. We've got, I started working in the ICU in 2011. And over that time, the use of indwelling catheters I just watched it decrease dramatically. There was a huge movement to round daily, assess the patient's need for Foley catheters, really aggressively getting them out as early as possible. And now we've got all these cool external collection devices like the PureWick catheter or the external PureWick catheter, which is fabulous. So there's all kinds of other really great things out there now.
Yeah, people can even have PureWick catheters at home, which has really changed people's quality of life with the chronic incontinence.
Yeah, they can retain their independence for a lot longer, which is really, really great. Okay, let's talk before we go. I want to talk about 2 other alternate options or 2 other types of things that we might see from a urology standpoint that we might not get a lot of experience with, which would be the suprapubic catheter or suprapubic tubes and nephrostomy tubes.
Yes. Yeah. So just the general indications for that. So a suprapubic tube is typically put in an individual that has chronic urinary retention for a variety of reasons. Let's say their bladder stops functioning, their prostate is too large. We've tried to get them to empty their bladder and they can't. And it's much more comfortable for them, right? Rather than having a chronic indwelling urethral catheter, which has all sorts of problems, not the least of which is urethral erosion. So what we'll do is with the surgical procedure is put the catheter directly into the bladder through the anterior abdominal wall. And that's what a suprapubic tube is. Now, it depends on where you are as far as whether nursing staff changes suprapubic tubes or not. I think they're certainly capable of it. But it's essentially a Foley catheter with a more direct access point to the bladder. And that's the way you should think about a suprapubic tube. So you can troubleshoot it in the same way that you do a Foley catheter. Flush it, use a bladder scanner, all these things. It's a very similar mechanism as a Foley catheter. And sometimes it's more convenient just because the catheter is sitting on top of their abdomen. So it's easier to access.
Easy to get to, yeah.
One thing that people should know about a suprapubic tube is what to do if the tube comes out. Now, provided you're at a place where nursing staff's allowed to put the suprapubic tube back in, it's beneficial to put it in as soon as possible once the tube is out, because those suprapubic tube tracts start closing up actually in a matter of minutes and hours.
Wow, that's some pressure.
Yeah, right. So, people don't realize that because a lot of times people think these tracts are so mature that they'll hang around for a few days. That's not the case. So it's important if you're going to kind of rescue that suprapubic tube tract and the patient avoid a future repeat suprapubic tube placement with anesthesia to replace the suprapubic tube as soon as possible. So that's one other kind of tip and trick with suprapubic tubes. As far as nephrostomy tubes go, Maureen, that's we could talk about upper tract stones and urinary obstruction. I could talk about it until tomorrow, but nephrostomy tubes are essentially a direct access point into the kidney to drain urine externally. And we do accomplish that with indwelling ureteral stents, but for a variety of reasons, some people can't tolerate a stent or we can't place a stent. So a nephrostomy tube is a direct drainage from the kidney itself. When nursing staff see the nephrostomy tube, in general, nephrostomy tubes don't need to be flushed. But sometimes there are orders to flush a nephrostomy tube. One thing you'll notice is if you are told to flush a nephrostomy tube and you put fluid in the nephrostomy tube, now this tends to be a Luer lock type syringe, a patient's going to experience some pain. They're going to feel the same type of pain as a kidney stone, right? Because that's what the pain is associated with the kidney stone. It's obstructing the flow of urine, and that back pressure on the kidney is very painful. So you may see that phenomenon when you flush a nephrostomy tube if you're asked to do that. So typically we don't need to flush nephrostomy tubes. They need to be changed out by interventional radiologists every 3 months or so, or until kind of their obstruction is relieved.
Okay. Yeah, we would flush them in the ICU, but we would flush away just to keep the catheter patent from or the tube patent from any, sediment or anything. But
great point.
Flushing toward the patient would be ouch. That would be an ouch. Right. Okay. I have a quick question about the suprapubic tube, because now I'm going to I don't know that I've ever had a patient with one, but of course, if I do, I'm going to be immediately suspicious that it's going to fall out, of course. So if I don't have a spare tube handy. Can I grab a sterile Foley catheter and use I should have mentioned that. So what suprapubic, that's a great point. So suprapubic tubes are just Foley catheters. When we put these tubes in, every urologist has a different way of doing it, but we put in a classic Foley catheter. In fact, if you look in with a cystoscope, I actually just operated on a patient with a suprapubic tube today, and you look in, you see the Foley catheter balloon from the inside entering the bladder, from the percutaneous site. So that's all it is. So yes, to answer your question, you want to get a Foley catheter that's the same size as the suprapubic tube that's in place, and just put it in there, and you have less distance to cover usually than with a typical Foley catheter placement. Okay, that's very interesting. All right, I'm going to ask one of the urologists next time I see them what they would think if we did that at the bedside, or if they'd prefer we called them instead. But I love that tip. That's really great.
Yeah, go for it.
Okay, well, Dr. Sehgal, I want to thank you. There were so many great tips here. I've got some tools that I can use when I have a patient with a difficult Foley insertion that I cannot wait to use. And I just know that it's going to be really helpful for everybody listening as well. So thank you so very much.
Yeah, it's my pleasure. I enjoyed it. And I hope that it's empowering to your audience.
It really will be. And then I want to remind everybody to visit Dr. Sehgal's YouTube if you want to learn more about urology and care of patients with urological conditions. And that's UroCoach, not the European, but UroCoach. And that is on YouTube. Thank you so very much.
It's my pleasure. Yeah, thanks for having me, Maureen.
This podcast is brought to you by Straight A Nursing.
Have you ever wondered what the science says about certain foods, products, or treatments? Does chiropractic actually work? Should I only buy organic foods? Are GMOs actually harmful? Is adrenal fatigue real?
We've got you covered. The goal of the Unbiased Science podcast is to dispel misinformation and misconceptions across an array of science and public health topics. We love to debunk myths and help arm our listeners with information so they can make evidence-based decisions. Make sure to tune in to the Unbiased Science podcast to get all of your questions answered.